Good morning, everyone. I'm Neil Love from Research to Practice, and welcome to Cases from the Community. As today, our investigator faculty will discuss available research guiding the selection of therapy for chronic lymphocytic leukemia. We do have a wonderful faculty here today, Dr. Matt Davids, starting at the far end of the stage here, Dr. Tam, Dr. Jennifer Woyach, and Dr. Bita Fakhri. As always, in all of our programs, we will be discussing the use of unapproved agents and regimens. So for more information, please check out the package inserts for the various products. We really take the opportunity to do CME very seriously. We spend a lot of time particularly trying to figure out what the docs in practice want to know about things. They're dealing with breast cancer, bladder cancer, myeloma, etc. So these are some of the docs that really we worked with over the last few months. You're going to see a number of them on the videos today. And we really appreciate the input that they provide, as well as the faculty. These are the faculty people we're working with over the next 2 weeks. The beginning of December is always really a lot of fun for us. So let's talk a little bit about CLL. Here are the docs. These are all general medical oncologists in community-based practice. They take care of everything. And these are the docs who are going to be presenting cases today. We really appreciate the fact that they're willing to share the way they practice with us and get some feedback on it. And actually, the first patient was a patient who one of our faculty saw as well, so we'll get two viewpoints on that. We're going to start out talking about certainly one of the biggest questions, I think, in CLL for many years now, optimal approach to first-line therapy. And Matt, we asked you to put together some slides on that.
Thanks so much, Neil. And I think it was almost 20 years ago was my first ASH, and I was a resident sitting in the back of one of your symposia on CLL. So I still have to pinch myself that I'm up here on the stage with you and all these great faculty. So really a pleasure to be here. I feel like every year we say in CLL, this is a big ASH for CLL. So I'll say it again. This is a big year for ASH in CLL, especially I'd say in the frontline setting. So we have this diverse array of targeted therapies now that are approved in CLL. Remember, unlike a lot of cancers, we're not going after genetically actionable mutations. We're going after the pathways that the CLL cells live on, and that's the B-cell receptor signaling pathway, where we have 4 different BTK inhibitors, FDA approved now. We still have PI3 kinase inhibitors for relapse patients. And then the BCL2 target with venetoclax. We often add the CD20 antibodies, and we also now have liso-cel, as we'll hear later, approved for CLL. So as we look back over the last 10 years or so, the treatment patterns here in the US from this database study have really changed. And so you can see back in 2014, chemoimmunotherapy in the green was very commonly used. BTK inhibitors were kind of just coming onto the scene. And over the last decade, you see that light blue line going up. That's the use of BTK inhibitors, while chemoimmunotherapy in the green is going down dramatically. You do also see venetoclax in the blue starting to pop up around 2019 with the approval of venetoclax plus obinutuzumab. But I think this really highlights that we've moved away from chemoimmunotherapy and toward targeted therapies here in the US. Why is that? Well, I would say covalent BTK inhibitors have revolutionized the treatment of CLL, and really no better example of that than our high-risk patients with TP53 aberration. So if we look back to the chemotherapy era, that's what the curve looked like. Median survival, 2 to 3 years from time of diagnosis if you had 17p CLL and you were treated with chemo. We've flipped that on its side now with BTK inhibitors like ibrutinib. This is 6 years of follow-up with an overall survival of around 80%. So really, this has been transformational for the disease. So we have 10 years of follow-up with frontline ibrutinib now from the RESONATE-2 trial, and you can see that the median progression-free survival is in the range of about 9 years. And importantly, unlike all the prior chemotherapy-based regimens, on the right, you can see patients with unmutated IGHV, which is a more aggressive form of CLL, did equally well as patients with the more indolent mutated IGHV. However, we know that discontinuation rates with ibrutinib are relatively high, mostly due to a variety of different adverse events. You can see sort of the long list from RESONATE-2 on the left, and then in the middle, just highlighting some of the more significant risks like hypertension and AFib, which can pop up years into ibrutinib treatment. So in the study, at 8 years, only a little over 40% of the patients were actually still on ibrutinib, and in most cases, that was due to coming off because of AEs. Real-world data sets have suggested that discontinuation rates are even higher with ibrutinib, upwards of 40% in this study at a median of just 18 months on therapy. So this was really the impetus to develop the more selective BTK inhibitors that have fewer off-target effects and in theory should lead to an improved safety profile. You can see the kinome plots here comparing acalabrutinib and zanubrutinib, which are much more selective for BTK than ibrutinib, and then the newest non-covalent inhibitor, pirtobrutinib, also highly selective, and hopefully avoiding some of the toxicities with ibrutinib that we think may be related to TEC, EGFR, and other kinases. From the relapse setting, we have the head-to-head studies. So this is ELEVATE-RR comparing acalabrutinib with ibrutinib. And although the efficacy was similar, you see significantly reduced rates of AFib and hypertension with acalabrutinib, as well as lower rates of discontinuation due to AEs. We have long-term follow-up now with acalabrutinib in the frontline setting. This was actually just published this year. This is ELEVATE-TN, 6-year update comparing acalabrutinib as a continuous treatment, either with or without obinutuzumab, to obinutuzumab with chlorambucil. You can see both acalabrutinib arms are superior. There actually is a little bit of an advantage of acala-obin over acala, although the study wasn't designed to look for a difference there. And on the right, you can see again, just like we saw with ibrutinib, patients seem to do equally well, irrespective of IGHV status. What about high-risk patients, TP53 aberrant? This is a pooled analysis across a few different studies where we looked at patients with TP53 aberrant CLL in the frontline setting, treated with acalabrutinib monotherapy or with obinutuzumab. Interestingly, there's no benefit of adding obinutuzumab in the high-risk patients, but regardless of the acalabrutinib regimen, the PFS is in the range of close to 80% at 4 years, with an excellent overall survival, similar to what's been observed with ibrutinib. Now, zanubrutinib has also been compared in the relapse setting to ibrutinib in the ALPINE trial. You can see here the adverse events were generally lower with zanubrutinib, particularly when it came to cardiovascular toxicities, as well as lower rates of dose reduction and a lower rate of treatment discontinuation due to AEs. Zanubrutinib also now has long-term data in the frontline setting with 5 years of follow-up in the SEQUOIA study comparing continuous zanubrutinib to BR. You see the PFS curves on the top, clearly favoring zanubrutinib, and at the bottom, again, favoring zanubrutinib with no difference based on IGHV status. For high-risk patients, zanubrutinib has been explored in Arm C of SEQUOIA, which is patients treated with zanubrutinib monotherapy if they have deletion 17p. Again, seeing excellent sustained PFS in the range of about 75% at 5 years of follow-up. Now, what about pirtobrutinib? So very selective, non-covalent BTK inhibitor. Turns out the non-covalent part of it makes a difference and really distinguishes this drug from the other drugs based on its ability to inhibit not only the wild-type BTK, but also common mutations that can arise in patients on covalent BTK inhibitors, such as the C481 mutation described by Dr. Woyach and others. So here you can see a waterfall plot from a relapsed refractory study called Bruin, where you saw dramatic reductions in the lymph node disease, even in very high-risk patients. In many cases, these were double-exposed patients, double refractory to BTK and to BCL2 inhibition, and still the response rates in the range of over 80%. So to highlight at this year's ASH meeting, there's a couple of very important phase 3 trials that will be reported out for the very first time. On the left, on Sunday, Dr. Woyach's going to report on the Bruin 313 study. This is looking at ibrutinib compared to pirtobrutinib head-to-head. Bit of an unusual design because it includes both frontline and relapse patients, but of course stratified appropriately for that. And this is a non-inferiority design and clearly shows that pirtobrutinib is non-inferior to ibrutinib. And I don't want to steal Dr. Woyach's thunder, so I won't say too much more about it other than I'm very excited to see the full presentation. On the right, you can see, and excuse me, that was the 314 study. The 313 study is the comparison of pirtobrutinib with bendamustine and rituximab in the frontline setting. This study was mostly done outside the US, as we're not using as much BR in the frontline setting, but it's a positive study comparing pirtobrutinib and BR with respect to PFS, and we'll see that in the late-breaking abstract session. And I think it's going to be interesting to see how these data sets are viewed in terms of potential for regulatory approval in the US and elsewhere for pirtobrutinib in the frontline setting. Now, of course, we also have great time-limited options. So far I've been focused on sort of these continuous BTK inhibitor strategies, but venetoclax and obinutuzumab has been around now for a while. 6-year follow-up from CLL14 continues to show excellent progression-free survival in the 6 to 7 year range. A little bit shorter in those patients with unmutated IGHV, as you see on the right, and definitely shorter in the patients with TP53 aberration, where it's about a 51-month median PFS. But remember, that's only with just 1 year of therapy. We also have robust data for venetoclax and obinutuzumab in the young fit population explored in the Gaia or CLL13 trial. And we also have a hint now with 5 years of follow-up from this study that a triplet with ibrutinib, venetoclax, and obinutuzumab may actually prolong progression-free survival versus ven-obin. This is mainly driven by the patients with higher risk unmutated IGHV. And so this is final analysis of this trial, and I think it's very helpful data. Now, we also have data with doublets of BTK plus BCL2. The Captivate study has been presented several times now. This is about a 15-month combination. It's actually 3 months of ibrutinib monotherapy lead-in and 12 months of combination, so a total of a 15-month regimen. And you can see excellent progression-free survival at 54 months of about 70%. Although, again, it does seem to be shorter in those high-risk patients with TP53 aberration, where it's only about 45%. In the older population, it's been more challenging to give ibrutinib plus venetoclax. We saw this from the GLOW study, which was the phase 3 trial comparing this regimen to chlorambucil and obinutuzumab. And although, as you can see, the efficacy looks excellent for I plus V, there is this signal of cardiovascular toxicity with ibrutinib, including 4 cardiac-related deaths in patients on induction therapy. So this has not been approved in the US, although it is used quite widely ex-US. We've been using this AVO triplet in a multi-center phase 2 trial that we published recently, and it's really focused now on high-risk patients with TP53 aberration. This is kind of a lightly MRD-guided strategy where we do essentially 15 cycles or 24 cycles, depending on whether patients achieve undetectable MRD. And in the bottom middle, you can see that the PFS for patients with TP53 aberration is about 70% at 4 years, which I think looks comparable, if not slightly better than venetoclax obinutuzumab, but of course, this is not a randomized study. We do have randomized data from last year's ASH meeting and this publication in the New England Journal on AVO versus AV and FCR-BR. This is the AMPLIFY trial. These are fixed duration AV-based regimens, so there's no MRD guidance here. So they're all about 14 cycles in length. And you can see here that the AVO triplet was the winner with respect to undetectable MRD rates at end of treatment plus 3 months. AV was a little bit lower across the board. And yet the PFS so far, with 3 years of follow-up, looks quite good for both of these AV-containing regimens. It's in the range of about 76 to 83% at 3 years. And you can see based on the hazard ratios that the benefit of the AVO really is mostly in the unmutated IGHV patients. Now, we also have sonrotoclax, a next-generation potent and selective BCL2 inhibitor that is now in the clinic and in phase 3 trials. You can see there are some differences in the chemical structure that lead to about a 10-fold improvement in the potency of sonrotoclax, at least when compared in preclinical models. And we saw some very impressive data at the ASH meeting last year. Early data on sonrotoclax with zanubrutinib seemed to be very active, with a CR rate in the range of about 40% and 90% or so of patients achieving undetectable MRD with these flat PFS curves. And I think we will see some updated data also at this ASH meeting. So sort of weighing the pros and cons with BTK inhibitors, we certainly have convenience as the all-oral therapy. We have that long-term efficacy data. There's still more data prospectively for venetoclax post-BTKI rather than the other order, but we have to contend with indefinite treatment and some of those cumulative cardiac toxicities. We now have a number of different Ven-based combination therapies that have this benefit of being time-limited with potential for MRD optimization, clearly lower cardiac and bleeding risks, cost savings, potential for retreatment, but the downside is the infusions with Ven-Oben and the venetoclax ramp up with all the regimens, a little bit more intensive. So just to wrap up, few studies to look for. This one you won't miss. It's abstract number 1 at this meeting, the CLL-17 trial in the plenary session. This was selected, I think, because it's the first time that we've seen a comparison of continuous to time-limited treatments. So ibrutinib monotherapy versus Ven-Oben and ibrutinib in separate arms. And so far, these strategies seem to be non-inferior to each other. The MAGIC study is ongoing, comparing MRD-guided AV as a doublet to MRD-guided Ven-Oben as a doublet. And this study is fully accrued, but we don't have data yet. And the Celestial TN study is the registrational trial for zanubrutinib sonrotoclax as a fixed duration of 15 cycles compared to Ven-Oben. This is a superiority study based on a primary endpoint of PFS. Also importantly, the CLL-18 trial is going to be the first to directly compare MRD-guided BTK-BCL2 therapy, in this case Perto-Ven, versus fixed duration BTK-BCL2 with a control arm of Ven-Oben. And this study is open and now accruing. And so as we kind of put this together for a practical guide for optimal frontline CLL therapy, this is in your packet. I won't go through it in detail in the interest of time, but as you can see, there's a variety of genetic factors, patient preferences, comorbidities that really go into this decision, and it's becoming a long conversation with patients having all these great options. So I'll stop there, and thank you for your attention.
Really amazing to look at that algorithm slide and think about what it would have looked like a couple of years ago. So we're going to get into some cases in a second, but just one quick follow-up, Matt. Any translational evidence in terms of sonrotoclax versus venetoclax, mechanism-wise? Any reason to think one would be different or more efficacious or less toxic?
Yeah, I mean, there's a couple of things. One is that preclinical potency data, which I think is a little bit stronger sort of in cell lines compared to primary CLL cells, where there's still some difference, but not as much. The other is that the half-life of sonrotoclax is shorter, and that might actually improve the sort of profile with respect to TLS risk.
That's interesting. We'll get into the TLS in a minute, too. So we're going to start out with a case of a 75-year-old man, a bunch of comorbidities, but good performance status, and actually it turns out that Jennifer actually saw this patient. I had to remind her a little bit about it, but she worked with Dr. Battinger on this case, and here's the case.
I have a 75-year-old man who has numerous medical comorbidities, including coronary artery disease, myocardial infarction, asthma, hypertension, and arthritis. He was originally diagnosed with Rye stage 0 CLL in 2019 and had been on watchful waiting until he developed warm autoimmune hemolytic anemia as a complication of his CLL earlier this year. He is co-managed at a tertiary care center and was recommended to initiate treatment with acalabrutinib 100 milligrams twice a day, and later start venetoclax on the basis of the Amplify trial. And so he started the acalabrutinib, but we folded in the venetoclax for him. And so my practice historically has been like a single agent BTK inhibitor for the majority of my CLL patients. And I thought the Amplify data were compelling, but I would love to hear from the CLL experts about what findings from the Amplify trial support the use of acalabrutinib and venetoclax in this clinical scenario, and why venetoclax is typically introduced after the initial phase of acalabrutinib therapy. Also curious to know how coronary artery disease and past myocardial infarction influence the safety profile and monitoring requirements for BTK inhibitors. And also, how should IVIG be integrated into the management for patients with autoimmune hemolytic anemia secondary to CLL? As a corollary, this guy's doing great. So he has completed that 5-week escalation of the venetoclax, no TLS. His blood counts look great, and he's really had no toxicity. So far, my N of 1 has been doing pretty well.
So, Jennifer, I don't know if you recall this man. Interesting. Incidentally, I guess tomorrow night's a big night for Ohio State. Playing a big football game tomorrow against Indiana. Good luck with that. But Annie, you got comments? I don't know if you recall this man, but also in general, how are you thinking through when to utilize the Amplify strategy? When are you using AV, AVO? Where are you today? We'll talk about where you're going to be next week, because maybe that'll be different. But where are you today, and where have you been this past year?
I think that the Amplify trial gave us some really great options to use for patients who desire a fixed duration regimen, but for some reason, either logistics, they don't want an infusion, for some reason they don't want or are not a great candidate for venetoclax or obinutuzumab. In this particular patient, actually the autoimmune hemolytic anemia was one of the reasons why we chose to start with a BTK inhibitor. There's some very nice data that BTK inhibitors are very helpful in the management of autoimmune hemolytic anemia. And this patient also desired a time-limited treatment. So as well, I think, with AV, you tend to get lower rates of neutropenia. It tends to be a little bit easier to dose escalate the venetoclax. In terms of AV versus AVO, I think Matt showed the really nice data suggesting that AVO produces higher rates of undetectable MRD, and in the patients with IGHV unmutated disease, it looks like AVO actually reduces the impact of that higher risk abnormality. So I'm using AVO for younger, fitter patients who have IGHV unmutated disease, and I will use AV in, like I said, in people who don't really want the infusions with VO, especially those with IGHV mutated CLL.
Bita, any comments again on time-limited therapy, AV, AVO, and also our first question here in terms of in general, how are you integrating therapy into autoimmune hemolytic anemia? When are you going for anti-CLL versus rituximab, steroids, et cetera?
Sure. So as Jennifer just brought up, there is good data with BTK inhibitors, but also autoimmune sequelae, in general, Evans syndrome. We know that basically the incidence doesn't have to do necessarily anything with the disease burden. You can have patients with MBL, monoclonal B-cell lymphocytosis, but really bad autoimmune sequelae. So patients, particularly with refractory autoimmune sequelae, recurring after treatment with steroids, rituximab, those are patients that I tend to go for putting them in UMRD remission because, the clone has a tendency to produce autoimmune antibodies regardless of the bulk of the disease. So if you put that clone in deep molecular remission, you are basically helping them with the autoimmune hemolytic anemia and other autoimmune complications that can happen in patients with CLL. So those are patients that I tend to go for UMRD remission. I like the idea of using BTK inhibitors, but I've also had a lot of success with OV, given the high rates of UMRD. And, AV is great, but, the UMRD, as Matt just showed, was low for these particular patients. And the other question, basically how it affects considering the cardiovascular comorbidities, the good thing, at least based on Amplify, patients get 2 months of BTK inhibitor to debulk the disease. So when you introduce venetoclax, they're at a lower rate of tumor lysis syndrome. So I think the 14-month doublet exposure reduces the long-term complications, particularly late toxicities like hypertension that we expect with BTK inhibitors.
So, Con, anything you want to add to that? How are you thinking through first-line therapy nowadays? And what about this man's history of coronary artery disease? He had a myocardial infarction, but he's in good condition. He recovered from that. How does that affect your approach?
Sure. So I will speak about that a bit further in the next talk. But the two thoughts that go through my mind would be, firstly, do they have a normal ejection fraction? And if they have a history of coronary heart disease, but a ventricle that is otherwise got a good ejection fraction, that wouldn't swap me from using the BTKI. The other thing that would go through my mind would be the requirement for antiplatelet drugs. So if he's on single antiplatelet drug for the coronary artery disease, that's fine. If they've got 16 stents in and they're on dual antiplatelet drugs long term, then that would worry me a lot about adding in a BTKI because of the bleeding risk.
So, I hear this expression for patients who would prefer to have time-limited oral therapy, and I'm like, well, who wouldn't want to have time-limited oral therapy? What is your experience, though? I'm curious, Con, in terms of, I hear more, well, maybe older people are not so much interested in time-limited. They're already on a million medications, et cetera. Do you see that split, or you see older people? According to Jennifer, this man was very interested in time-limited therapy.
Most of my patients are interested in time-limited therapy when given the option, provided that it can be delivered in an easy fashion. So intravenous obinutuzumab is a deal breaker for a lot of patients, as is the requirement for tumor lysis monitoring.
Right, and of course here now you have BTK instead. All right, let's hear about a couple other cases. And Matt, when you talk to general medical oncologists, they're always bringing up cases like this of patients on anticoagulation. First patient from Dr. Iannucci, a 50-year-old man, Jehovah's Witness, incidentally IGVH mutated disease, as you'll hear, developed pulmonary emboli, also progressing in CLL, had to be anticoagulated, got started on zanubrutinib. And Dr. Lamar's patient, a 75-year-old man, already on anticoagulation for atrial fibrillation and also received zanubrutinib.
50-year-old gentleman, active duty, military, diagnosed with CLL. He had an initial PET scan that showed mediastinal retroperitoneal adenopathy. He was asymptomatic. About a year and a half later, he developed abdominal discomfort, fullness, just kind of increased fatigue and shortness of breath. He had a CTA. He actually went to the emergency room for shortness of breath that showed multiple pulmonary emboli, as well as significant enlargement of his lymphadenopathy, 8-centimeter mesenteric lymph node mass. He was started on Eliquis for his pulmonary emboli. And for him, we did talk back and forth about what would be the best upfront treatment for him because he was on an anticoagulant. And then we ended up starting him on zanubrutinib. He's responding well, and the plan is for indefinite treatment for him. My main question to the faculty would be upon the need for treatment in the setting of his pulmonary emboli. Would anybody have done anything different? As a side, he is a Jehovah's Witness. I was worried about bleeding. Another question for the faculty would be, how do you decide between acala and zanubrutinib as first-line treatment when you're deciding on treatment with a Bruton's tyrosine kinase inhibitor?
How about your 75-year-old man with atrial fibrillation on anticoagulation?
He was started on zanubrutinib and responded well to therapy, but had significant bruising. We actually dropped him from full dose of the apixaban to half of the dose, and the bleeding reduced. However, the cardiologist was concerned about that dose reduction. The conversation I had with the cardiologist is like, hey, can we do a procedure to essentially get this person off anticoagulation? And the cardiologist says, hey, don't we have other treatments for CLL? Do you ever consider potentially treating those patients with pirtobrutinib, or are you expecting the same toxicity profile?
Any other questions about this case?
A lot of patients are very interested in time-limited therapies. And so in those patients, are you all routinely looking at MRD?
So, Matt, any thoughts about these cases, these situations?
Yeah, so I mean, the first case is a bit unusual. Mutated IGHV and within 1 year has bulky lymphadenopathy, so something else might be going on here, first of all. So I would want to get a PET scan on this patient, make sure the LDH looks okay and that we're not dealing with Richter transformation. But assuming we're not, then I do think, BTK inhibitor is a reasonable option here. However, it's a 50-year-old man, and so that's going to be a lot of BTK inhibitor therapy. There's already the need for anticoagulation. So if feasible, this is a patient I would really prioritize for venetoclax over inotuzumab because minimal bleeding risk there, especially with the Jehovah's Witness aspect. If this patient had a bleed, it'd be difficult without transfusions. So I think in terms of there was a question around acala versus Xanu. I do think of these drugs as being pretty similar, although I will note that in Elevate-RR, there was a reduced risk of all-grade bleeding with acalabrutinib. I think it was around 9% versus 23% with ibrutinib, whereas in that Alpine head-to-head study, the bleeding rates were pretty similar between zanubrutinib and ibrutinib. So I might lean a little more toward acalabrutinib in this patient. Maybe it has a little bit of a lower bleeding risk, but we don't have, obviously, head-to-head data of acala versus Xanu to know that.
Bita, anything you want to add to that? And also, what about the issue of pirtobrutinib and bleeding?
Yeah, so pirtobrutinib, being the first non-covalent BTK inhibitor which recently got the FDA approval after covalent BTK inhibitor, it is associated with a favorable safety profile, but there is still a risk of bleeding. So exactly, Matt's thoughts. If you're worried about the risk of bleeding in a Jehovah's Witness, I would try to present the venetoclax-based therapies in a more convincing fashion for that patient.
So, Jennifer, anything you want to add to this question of acala versus Xanu? I hear people, thinking of different shades. Is it hypertensive patient, maybe one way, et cetera, a patient with migraines, et cetera? Anything that gets you shaded in one way direction or the other?
Yeah, I think you're hitting the nail on the head. Like, these drugs are much more alike than they are different. So there's, a few things that might sway you one direction or another. There's very few situations, if any, where one is right and one is wrong. I think, a couple advantages to Xanu would be that you can dose reduce it a little bit easier. So if you felt like it was someone that you may have to do a dose adjustment, I think that is a little bit easier with Xanu than acala. As you mentioned, somebody with headaches, you might choose zanubrutinib rather than acalabrutinib. Somebody with hypertension, you might choose acalabrutinib rather than zanubrutinib. The risk of significant bleeding is pretty much the same with the two. And I think actually over time we're seeing that the risk of atrial fibrillation is pretty similar as well.
So, Con, what about the issue of MRD assays? First of all, is that an appropriate assay for a general medical oncologist in community-based practice to be looking at in CLL, and in what situations?
So, at the moment, most of our regimens are fixed duration, irrespective of MRD status. And we know that patients who take a fixed duration regimen in general do very well. Those who are MRD negative do better than the ones who are MRD detectable, but in general they do well. So in terms of making a decision for your patient, the MRD result actually doesn't change your decision making. If you do get it, the role of it is really to reassure yourself and the patient that you've done very well. Then you have to deal with the anxiety of the patient who's got low detectable MRD. I think there are studies that show that if you have the capacity to give prolonged therapy, for example, the UK group used a combination of ibrutinib and venetoclax, MRD guided, and some of those patients are on treatment for 3 to 6 years of doublet therapy. They actually have some of the best outcomes I've ever seen in CLL, but that's very prolonged treatment and not one that I will regard as standard practice.
So, Matt, kind of a simple, basic question. I'm a simple person, but are we going to be thinking about pirtobrutinib in the first-line setting after this week?
Yeah, I mean, we are. We're going to have 2 robust phase 3 data sets that have read out, but I think there's a couple of challenges that we need to consider. One is that the follow-up is very short on both of these studies, median follow-up in the range of about 2 years in a frontline population, so we're going to need longer-term data. Secondly, we know that we can start with covalent BTK inhibitors and that pirtobrutinib will be efficacious in the second and later lines of therapy. We don't have data the other way around yet, so what happens if we start with pirtobrutinib? Do patients then respond to covalent BTK inhibitors in the second-line setting? Don't know. I would say, though, the safety profile, I think, is going to look really good for pirtobrutinib. And if it's an older patient, that might be their only line of therapy that they need. And so we might think about pirtobrutinib frontline for an older patient with comorbidities, and that's very reasonable.
Jennifer, anything you want to add to that? What are you thinking?
I completely agree. I think that the older patients where you may be able to treat them just with pirtobrutinib and maybe venetoclax following are definitely patients I'd consider for frontline use of pirtobrutinib. And then maybe some of these frail patients who for some reason are not going to tolerate or you think they will not tolerate a covalent BTK inhibitor. I think these data are going to show that it's reasonable to choose that as an option. I agree, though, the long-term follow-up is going to be really critical.
So, Bita, in the future or in the near future, are we going to be looking at time-limited Xanu venetoclax? Are we going to be looking at time-limited Pirto venetoclax?
I think the future of the CLL is definitely moving in the direction of time-limited therapy. It is important to just use MRD guidance, I don't think for all. I see mutated IGHV and unmutated IGHV patients very differently. And I'm afraid if you use MRD-guided duration therapy for all, there is a risk of over-treating our patients with the best molecular features, basically over-treating our mutated IGHV patients who do not necessarily need to get to that UMRD. And, the Sequoia cohort of Xanu plus venetoclax was very promising. Pirtobrutinib plus venetoclax, again, has the challenge of what you heard from my colleagues. Introducing pirtobrutinib as the first, basically, BTK inhibitor, the lack of long-term follow-up data, and also not knowing after patients progress on a non-covalent BTK inhibitor, are they going to respond to covalent BTK inhibitors, which have passed the test of time? Those are the challenges that need to be addressed.
Just a quick follow-up back to you, Jennifer, in terms of older patient with comorbidities. What about just the older patient without any particular comorbidities? Mm-hmm. More likely to think about pirtobrutinib in an 80 or 85-year-old?
Again, I think it will be really helpful to see a little bit longer follow-up from these studies, but I would consider it for somebody who's in their 80s already, because we do know that venetoclax is an acceptable salvage therapy after pirtobrutinib, but it might be a good option for some people.
All right, so we're going to move on now, and Professor Tam's going to talk about really a huge issue that we deal with in CME ever since these agents come about, which is adverse events. And it's great that we have these new biologic, but we still have a lot of adverse issues to consider. So, Con, please take it away.
Thank you, and thank you for the invitation. It's a bit unusual to have an Australian in a predominant US population, but I've been very lucky to have really dealt with all the drugs from a very young age, from when they were in phase 1. So I can speak to you about quite a bit of experience with all of these drugs.
I love it when we do webinars with people from Australia, because I always realize that you're in tomorrow. They live in tomorrow.
So this slide really summarizes my view on when you choose between a BTKI and BCL2, of which, of course, venetoclax is the only drug you have available. And Matt has already gone through all of these points. I would choose a BTKI because it's effective across all the prognostic groups, it's easy to give, it has a low risk of tumor lysis, but the disadvantage is that it's continuous therapy and there are the increasing recognition of cardiovascular and bleeding side effects, which I will speak to you about. Venetoclax, obviously very attractive because it's limited duration therapy. but there is the risk of tumor lysis, and in certain biologic subsets, it does perform less well than BTKI. In terms of drug interactions, the most important thing to remember are your strong azoles. You can dose reduce 3 of the drugs, and for acalabrutinib, there's no guidance. You have to hold the drug. PPI used to be a problem with the older formulation of acalabrutinib, and I'll speak to you later about the choice of antiplatelet agents and anticoagulant with a BTKI. So I use this slide to remind myself and everyone about the bleeding risk of BTKI, and I tell all my patients on BTKI to stop the drugs before any surgery. You need to understand that many surgeons do not recognize a BTKI as an antiplatelet agent, and the patient has to take charge of it. So these are 2 of my patients. They both have skin cancers removed from their head, and they didn't stop their ibrutinib, and I didn't get a call until 3 or 4 days later from their surgeon who say, I don't know what's wrong with the patient, but they can't stop bleeding. And the reason why is because they're on probably the most potent antiplatelet drug ever discovered in mankind, which is ibrutinib. So you have to stop the drug before surgery, otherwise they will bleed. So I was very lucky in that our group was discovered the mechanism of bleeding behind ibrutinib. This is a really old-fashioned test. It's called platelet aggregation. It takes a scientist about 3 or 4 hours to do. So I think in the US, you guys just cannot do it at all because it's just too expensive. But we still do it in Australia. So this is one of our early patients showing that if you are on ibrutinib, that you have a reduction in your platelet response to collagen. It turned out that the collagen receptor, which is glycoprotein 6, is actually signaled through BTK. And if you stop ibrutinib, the collagen curve goes back to normal, and if you restart it, the collagen curve comes back down. And this does not happen just with ibrutinib. It happens with zanubrutinib, it happens with acalabrutinib, it happens with pirtobrutinib. This is an on-target effect of BTKI. In fact, boys who are born without BTK, so Bruton's agammaglobuline boys, look just like this when you test them. So all of these drugs are antiplatelet drugs. So with the passage of time, BTKI are amazing drugs, but the 3 side effects I want to talk about are an ongoing risk of bleeding due to the risk, the antiplatelet effect, an ongoing risk of atrial fibrillation. It doesn't ever go away. It's an ongoing risk, but more importantly, a cumulative risk of hypertension. And we now know that hypertension is probably the major contributor to atrial fibrillation. So if you don't manage a patient's hypertension well, they will get cardiac arrhythmias. So this is where the 2nd-generation drugs really come into their own. So both Xanu and Acala are more specific than ibrutinib. So the only thing special about the 2nd-gen drugs are that they have got lesser toxicity because they have a more favorable Carnon profile. And there are actually 3 phase 3 studies comparing ibrutinib versus a 2nd-generation drug. So there are 2 with Xanu and 1 with Acala. And I've just summarized the results of toxicity with respect to these phase 3 drugs on this slide. So if you look at atrial fibrillation, you see that across all 3 studies, and this includes the study in Waldenstrom's macroglobulinemia that nobody seems to talk about, but there is, in fact, the first head-to-head study was actually in WM. There's a reduced rate of atrial fibrillation. There is no doubt that 2nd-generation drugs are much safer in terms of atrial fibrillation. For hypertension, as you know, there's a reduction in elevate RR, none in Alpine, but there was a reduction in Aspen, which is the Waldenstrom study for zanubrutinib. So I would say in aggregate that hypertension is reduced with the 2nd-generation drugs. Maybe the evidence is stronger for acalabrutinib versus zanubrutinib. Now, although there are minor differences in the bleeding risk, in minor bleeding risk, which on the head-to-head studies, there is actually no difference in major bleeding risk. So this emphasizes that all of these drugs are potent antiplatelet drugs, and you need to take care of all of them. The side effects I worry about the most, and this discussed, is the patient who drops dead and never comes back to your clinic. So we now know that sudden death or ventricular arrhythmias is an on-target side effect of the BTKIs. Happens in about 1 in 200 patients on ibrutinib. And it's devastating because your patient just do not wake up. And this is a side effect that is not just of ibrutinib. It's a class side effect, but with the more specific drugs such as acalabrutinib and zanubrutinib, there is emerging data that they are probably safer than ibrutinib in terms of these side effects as well. And it's probably the tip of the iceberg. So the tip of the iceberg is atrial fibrillation, but the major risk is actually the ventricular arrhythmia. And if you can use a safer drug in terms of cardiovascular risk, you will hopefully reduce this devastating complication. So how do we manage the cardiovascular issue in the BTKI-treated patient? So at least as a hematologist in my country, I have learned to be a cardiologist as well when I see my patients. Because very few of my cardiology colleagues are interested in this. I know you may have cardiac oncologists who are interested, and mine are not. So this is what I do. And this is partly my experience and partly based on the international guidelines published in Blood Advances, of which I am very fortunate to be an author on. So I take a personal and family history, clinical examination, blood pressure, get baseline ECG, and then I will only do an echocardiogram if there's a history of cardiovascular disease or poorly controlled hypertension. So most patients who are otherwise fit and well do not require an echocardiogram. And then on the right, I would avoid a BTKI if there is a family history or personal history of ventricular arrhythmias or sudden death. I will avoid it if there's uncontrolled hypertension until it comes under control. And then if there's an abnormal LVEF. Now the international guideline says do not use it if the LVEF is less than 30%. I have to say that I actually am not comfortable even at thresholds around 40 to 45%. And where possible for those patients, I will use venetoclax or at least use BTKI with great caution. And that's because of the ventricular arrhythmia risk. In terms of hypertension, once you get started, I ask my patients to home monitor weekly for 3 months and then monthly monitor their blood pressure, and the target for treatment is given on the right. You're aiming for a target of less than 135 on 85 and prescribe ACE inhibitors or ARB as over others. Once again, this is something that we try to farm out to my cardiologists and the general practitioners, and it never seems to get done. So ultimately it becomes my responsibility. Atrial fibrillation, I check the pulse every time for clinical AF. There are some guidelines to suggest that you can consider doing an ECG every 3 monthly. I find that to be impractical, but we should do it in your practice. But if there's a suspicion of atrial fibrillation, then you definitely need to do an ECG. You should do an echocardiogram if they're in atrial fibrillation to make sure that the heart is still normal. Beta blockers are the preferred way of managing atrial fibrillation in patients taking BTKI AF. And if they have a high CHEVS score, then I would prescribe apixaban as well. And my preferred dose of anticoagulation in these patients is apixaban, and I have traditionally used 2.5 milligrams BD just because that is the risk, the dose that has a reduced risk of bleeding. Moving on to venetoclax. So everyone knows that venetoclax, the major side effect is tumor lysis. These are actually the first 3 patients in the world to get ABT-199 or venetoclax. And they were all treated in Melbourne, and back then we thought that 200 milligrams was the right starting dose. How wrong we were. And you can see that in all 3 patients, they all had a rapid reduction in the white cell count within 8 hours. This is in the red, and all 3 patients had a rise in the LDH. So this is just a reminder that tumor lysis syndrome is the major problem with venetoclax, or the major clinical issue. We now know that we should start at 20 milligrams and not 200 milligrams, and using this weekly step-up schema, this has proven to be very safe across all the studies. I have listed the table there for your reference. I don't expect you to read through them. The points to note are that the high tumor lysis risk patients are the ones that have a lymph node above 10 centimeters, or the combination of a high white cell count and a lymph node between 5 to 10 centimeters. Those are the high-risk patients. Everyone else are low to intermediate risk. The other thing to note is that the risk changes with time. So if you have a patient who starts off as a high-risk patient because they have a lymphocyte count of 100 and a moderate-sized lymph node, and by the time they go to 100 milligrams, the lymphocyte count is normal, that person is no longer high risk. That person is now intermediate risk and can be managed as such. So that risk changes as you dose escalate. I also want to just quickly talk about the other BTKI and BCL2 side effects that people often talk about. And the first one is the nuisance side effects. These are the myalgias, the arthralgias, the doctor, I don't feel well, I've got a cough. And those are mainly seen in ibrutinib and probably off target. And if you use a second generation drug, such as Xanu or Acala, or even pirtobrutinib, those side effects go away. Neutropenia are more common with venetoclax and zanubrutinib, but at least in my experience, neutropenia is more about a problem, a paper problem, than a real clinical problem. So patients will often come in, they say, how are you feeling? Fantastic, doctor, I'm doing well. You're about to send them out, and thought, better check your blood count. Neutrophils are 0.5. Perfectly well. So usually for those patients, I would prescribe G-CSF for 4 weeks, and then I check it, and it goes away, and I stop it, and it never comes back. So we don't usually have to dose reduce either of the drugs based on neutropenia, and it's almost never associated with infections. The nausea, dyspepsia, and diarrhea are mainly seen in ibrutinib and venetoclax, and you can try dose reducing your ibrutinib, or you can try nighttime dosing your venetoclax. So for venetoclax, it tends to happen about 4 hours after you take the dose. So if you take it at 8 p.m. at night, they go to sleep and they don't get the nausea when they're asleep. Headache, mainly seen in acalabrutinib, you all know, goes away with caffeine and a bit of patience. So I want to finish off on the BTK plus BCL2 combinations because there are now these combinations available. So the first one is ibrutinib and venetoclax. And the main issue with that combination is that they both cause diarrhea. And when you add the two together, they cause a lot of diarrhea. So if you do use this combination, I find it very useful to split the dose. You can take acalabrutinib in the morning and venetoclax at night, and that usually takes care of the diarrhea. And I would imagine that if you're going to use Acala plus Van and you get diarrhea, that you can try the same thing. We all know that this combination increases the risk of cardiac death in select populations, such as older patients, or funny enough, in patients with Waldenstrom's. There's actually a WM study testing this combination that had to be terminated because there's a 10% ventricular arrhythmia rate, and used with extreme caution with elderly comorbid or cardiovascular disease. The second generation drugs are much better tolerated in terms of GI toxicity, and I think that's where Acala Van really comes to its own. It's easy to take, it's effective, it's all oral, it's limited duration. The cardiovascular safety for the second generation drug combinations also seem to be better. What about adding in the obinutuzumab, the anti-CD20? And the main price to pay for adding the obinutuzumab is that there's an increased risk of severe infections, and this is mainly seen in the COVID era, where there's an increased death from COVID, and then there's also an increased risk of neutropenia. And with that, I want to stop and thank you for your chance to talk about my experience. Thank you.
Thank you. That was great. I learned a lot on things I never heard before. A couple of questions I have. The audience has a bunch of questions. We want to get to the cases, but I didn't. You had that really cool slide there with the ventricular arrhythmias with ibrutinib and Acala. What about Xanu and Pirto?
Yep. So zanubrutinib, the pooled data suggests that the risk of ventricular arrhythmias is about half to 1/3 the risk of ibrutinib. So this is based on the aggregate experience. For Pirto, we have not seen the data for Pirto just because it's a rare indication. It takes a while for people to report it. But I would be really surprised if none of these cases get reported with Pirto. I'm sure it's a class side effect.
So, Matt, I've heard about headaches with Acala so many times that I'm amazed. I actually was thinking about what's the pathophysiology of why they get it? Why would they get it and the other BTKs don't get it? Why does caffeine work or does it work? What's your experience with it?
Yeah, great questions. Short answer is I don't know. There is some sort of adaptation effect of acalabrutinib where the body is sort of getting used to it in some way. For some reason, that doesn't seem to be the case with the other BTK inhibitors, but I don't know why.
So again, a lot of great questions from the audience. Jennifer, a patient is on ven-obin but can't tolerate obin or develops a hypersensitivity reaction to it. What about single agent ven?
So there is actually quite a bit of data for single-agent ven in all lines of therapy. And what I have generally done in that situation is you could consider using rituximab rather than the obinutuzumab. It is from the CLL13 study. We know that it's probably not going to work as well in terms of inducing those MRD undetectable remissions. I also have just completed the course of venetoclax by itself, looked at MRD at the end of therapy, and then considered giving a little bit more venetoclax just because they didn't receive the obinutuzumab.
Bita, another great question from the audience. Do you see patients acquiring del-17p? And if so, what do you do?
So for TP53 aberrant patients, I certainly prefer BTK inhibitors in definite therapy, but there is also really good data with MAT's AVO. So if they're younger, time-limited therapy makes a lot of sense for those patients. So AVO would be my preference. But if they're older, I think indefinite covalent BTK inhibitor makes a lot of sense.
But I mean, do you see people acquire del-17p? How often is that? And do you retest?
Yes, definitely. I mean, clonal evolution is a very real phenomenon in CLL, and normally I don't retest for FISH panel unless the behavior of the disease changes. So, someone has been indolent for quite some time, and all of a sudden their disease has started behaving more aggressively. That's the time that I check for CLL FISH panel, and I also definitely recommend checking for CLL FISH panel every time that we are trying a new line of therapy.
All right, let's get into some of our cases from our general oncologist. This is a patient of Dr. Rupard's who he was asked to see in consultation in the hospital. When he walked in the room, got a very big surprise.
So I saw him in his room, saw this impressive scalp lesion, realized right away that was his chief complaint and really his number one issue. He did not require treatment for his CLL. A local surgeon did a biopsy of kind of one of the edges of this scalp lesion and found that it was a Merkel cell carcinoma. And in reviewing this, I found that all skin cancers, with the exception of melanoma, interestingly, the other three, basal cell, squamous cell, and Merkel cell, are a bit more common in men who have CLL. And in fact, Merkel cell is substantially more common. He was treated with surgical resection, had positive lymph nodes in his neck, and I'm told that he passed away from his Merkel cell carcinoma about a year later. I'm curious from your faculty how often they're seeing these CLL-associated skin cancers in patients and whether or not they can become problematic enough that it alters the way that you're going about treating the CLL.
Any insights in terms of why he presented with such an advanced lesion?
Yeah, he was a farmer, and he, if he didn't do it around his farm, nobody was going to. So he just kept working and working.
Khan, any comments in terms of skin cancers? Actually, this afternoon we're going to talk about ruxolitinib and skin cancers. Is it an immune pathophysiology, and what actually do you see? Seen any cases like this?
Yeah, unfortunately, I live in the country. If you look on the map of the world, the area that has no ozone layer is Australia. So we have a lot of people with pale skin in a lot of sun and no ozone layer. So we have a lot of skin cancer. So several comments. So firstly, it is they're greatly increased at risk. They're much more aggressive, both melanoma and non-melanoma, in terms of frequency, the capacity to spread and metastasize. They're a lot more aggressive. And anyone with CLL is probably related to the immunology, that the immune suppression state of CLL patients. We have felt at some point that maybe chemotherapy, maybe when you go to novel therapy, that the risk of these things will be lower, but it has not. In fact, the novel therapies have not changed the natural history of the skin cancers. And more of my patients have died of skin cancer in the last 10 years than of the CLL. So those are general comments.
Jennifer, can you put in context in general second cancers in CLL, to start with just by having CLL, what types of second cancers you see, and then whether any of these are increased with various treatments?
Mm-hmm. So, as mentioned, there is a higher risk of secondary cancers, and I think the non-melanoma skin cancers are one of the ones that has especially increased risk, and Merkel cell, as mentioned, is one that is very rare, but is more frequent in CLL than you would expect in the general population. I also just tend to tell my patients that anything that is common in the general population is probably going to be a little bit more common in people with CLL. There are really, unfortunately, not a difference in how we screen people, except for skin cancers, which we recommend annual dermatology screening. And, just having seen also a lot of these very advanced skin cancers, my general practice is always talk to the dermatologist to make sure that we're being aggressive enough with some of these locally advanced skin cancers.
All right, let's go on to another case. This is a younger patient, a 53-year-old woman who initially was observed IGVH unmutated CLL, but interestingly, she develops really symptomatic splenomegaly without adenopathy or even much dramatic increase in her white count, and gets treated with obinutuzumab venetoclax.
Over the last few months, she developed some left upper quadrant tenderness. We did a CAT scan, which revealed a spleen that was over 20 centimeters. It had been 15 centimeters 1 year prior. And then that sort of got my attention. A full mutational study shows a 13q deletion, IGHV unmutated, and no TP5317q deletion. Based off of these factors, we started her on the combination of venetoclax with obinutuzumab. And just a couple questions. I'm just curious if anyone's ever seen this as far as isolated splenomegaly as an indication for treatment. I think for her, we needed to do it. She was pretty uncomfortable and the spleen was only growing, but just curious if that's something anyone else has seen. I think all things being equal, I prefer fixed duration. She didn't have the TP53 mutation. We did the doublet, but would there be any indication to add in acalabrutinib to venetoclax obinutuzumab? And then I guess the last question, I know when I was in fellowship, there was a lot of FCR, and we were saying, in very young patients, you'd still consider that. But I'm just wondering, out of curiosity, is there really any role we see nowadays for FCR, or is that a treatment of the past?
What are you doing about TLS prophylaxis, and how do you classify her in terms of TLS risk?
That's a good question, because usually the splenomegaly would go hand in hand with just sort of the diffuse lymphadenopathy. TLS is definitely something to be concerned for, and I'm curious to see what people think if splenomegaly itself could increase the risk of TLS.
So, Bita, have you seen patients like this with mainly splenomegaly, and how does it affect the way you think about TLS prevention?
I actually have seen, and I've also seen only transformed DLBCL in isolated splenomegaly. So I am curious to hear about the LDH and other B symptoms in this patient. And these are patients that I actually do PET CT because I want to know the FDG avidity of the spleen. But assuming this is CLL, all CLL, in the DLBCL patient, we actually ended up doing splenectomy. But assuming this is all CLL, SLL in this case, so yes, a spleen of 20 centimeters definitely puts the patient at high risk for TLS. And how I manage it is putting them on allopurinol, based on the risk categorization twice a day, 300 milligrams twice a day, IV fluids. And, basically when you are doing obinutuzumab venetoclax, the engineering, the design of the trial is in a way that 3 grams of obinutuzumab before introducing venetoclax significantly reduces the risk of tumor lysis syndrome. I think the hardest part is the first dose of obinutuzumab, which is 100 milligrams test dose on day 1 and then 900 milligrams on day 2. So making sure that patients start their allopurinol 3 days before starting obinutuzumab, adequate IV fluids, making sure that they don't become volume overloaded. And a patient like this is also at high risk for infusion-related reactions with the first dose of obinutuzumab. So that very first dose is the hardest part for any practice. And when they get to the venetoclax ramp-up on day 22, the majority of these patients have been debulked to a level that they're at lower risk for TLS. And also, although I don't like doing frequent imaging as part of response assessment for CLL patient, but a patient like this that you really need to know, how they're responding to treatment, not necessarily physical exam is great, but this is a patient that I would also do imaging, maybe when they get to the venetoclax 400 milligrams, 2-3 cycles into the treatment, because I'm curious to see how they're responding to treatment.
So, Jennifer, I got a big surprise in preparing. We did a session this morning on AML, and after years of talking about HMA venetoclax, for the first time I heard them talking about TLS. I mean, very rare with AML, but you guys talk about it all the time. I never heard it with AML. At least they brought it up as a thought. I'm curious, anything you want to add to what Bita said in terms of TLS prevention? Also, I know at one point you all at Ohio State were doing an accelerated inpatient ramp up. Are you still doing that, or any indications to do that? And also any myths or misperceptions you see people doing things in the community, then you come in a second opinion that maybe you wouldn't do in terms of TLS prevention?
Definitely agree with what Bita said regarding TLS prevention. One other thing I might add for a case like this is BTK inhibitors really shrink spleens relatively rapidly and don't have any risk of TLS compared with obinutuzumab, which in the CLL14 study, the only people, which was the venetoclax obinutuzumab, the only people that actually got TLS got it with the obinutuzumab. So I think venetoclax obinutuzumab is a great regimen for this. I might also consider acalabrutinib venetoclax here. We do still do some accelerated ramp up of the venetoclax, and I think other people do as well. And I think Matt is doing a trial of it too. We started doing it for people with highly refractory disease where we really needed to get up to the dose of venetoclax that was going to work relatively quickly. We don't see that as much anymore, and especially when you're using venetoclax in combination with another active agent that you're starting first, you have a little bit more time to increase the dose of the venetoclax. I still do this occasionally in those type of patients, and also sometimes, honestly, we do it just for convenience too. If somebody wants their treatment with us but live very far away, sometimes it's easier to come into the hospital for a few days.
Matt?
Yeah, I was just going to add, so we have a prospective trial that we call SAVE. It stands for Safe Accelerated Venetoclax Escalation. We reported the early results at ASCO a couple of years ago now with the first 20 patients. We now have 40 patients that we've treated with daily ramp-up inpatient. We've only seen one case of some laboratory TLS that was very easy to manage. We had designed the study initially for that population that Jennifer was just describing, a sort of more aggressive post-BTKI population. Turned out the patients who wanted to go on the study were often frontline patients, and they just wanted the convenience of being done with the ramp-up in 1 week. And so it's been very popular for some of our patients.
Anything you see, again, Matt, people doing in the community and as regards to TLS prevention that maybe you wouldn't do? And also, how do you factor in splenomegaly? I'm not sure it's in that package insert thing.
Yeah, splenomegaly is not. It didn't come out in the initial analysis that led to that TLS risk stratification, but that was based on a pretty small number of patients. So I do still try to take extra caution with splenomegaly just in case. One thing that I've seen now more in practice, the label has changed with venetoclax now for low and sort of medium risk patients. They don't necessarily need that 6 to 8 hour lab in the sort of, especially in the later weeks, 3, 4, and 5. So I feel like that has been a simplification that's been helpful in clinical practice, that they can just get the 24-hour labs, and in some cases, if they're very low risk, they don't even need those.
So another question from the audience, Con. Any situations where you would want to start therapy in an asymptomatic patient who doesn't meet the typical criteria, high risk, any other clinical situations where you would treat a patient who's asymptomatic?
So I think the short answer is, and the official answer is no, that we should meet symptomatic criteria before we treat a patient. The reason why is there are some patients, but half the patients will never need treatment in their lifetime. So why is you subjecting the patient to a treatment when there's a chance they don't need it? Have I done it in real life? Yes, I have. There are some patients who cannot handle the psychology of watch and wait, for example. There are a lot of patients whose life, after diagnosis of CLL, every moment of the time is obsessed with the CLL. They can't go to work, they can't look after the family, and there are those occasions where I've given treatment at least just to take the CLL off the mind and allow them to go back to life.
I treat those patients too, but with an SSRI.
Interesting. One quick final question back to you, Bita, from the audience. I'll just read it. Should we use PJP and VZV prophylaxis on patients on long-term BTKI due to possible decline in CD4 count, hypogammaglobulinemia? Should we check CD4 immunoglobulins periodically?
So with BTK inhibitors, my short answer is no. And I want to basically quote Michael Halleck. BTK inhibitors, they change the dialogue between the CLL cell and the environment. And eventually they'll, through multiple mechanisms, they will result in an improvement in basically cell immunity. So unless we are using steroids for whatever reason, prednisone, basically 20 milligrams or equivalent for 3 more weeks, then a patient will need PJP prophylaxis. again, antiviral prophylaxis is very case-based. If someone has had bad history of, zoster or basically recurrent HSV infection, then in that case it makes sense. But just being on a BTK inhibitor, indefinite therapy, and then the polypharmacy associated with antimicrobial therapy were truly not indicated, makes patients' life even more inconvenient. So no, because the premise of BTK inhibitors is improved immune modulation, so there is no need for PJP prophylaxis and antiviral therapy for all.
One final question back to you, Matt, in terms of, I can't even remember what the question was. Sorry, I'm blanking out. But I think, I know, chemotherapy. Yeah, so Matt, the issue of FCR was brought up. I know not too many people bring that up, but a lot of people bring up BR as a possibility. Are there situations where you use BR?
I would say sort of one situation would be a patient who maybe has very high out-of-pocket costs for the oral therapies. Outside of that, I'd say no.
Is it true that people are still still getting chemo out there in the real world, so to speak?
It is true. I mean, I think based on sort of the research database studies, there's still a significant number of patients getting BR. It is true that it's an effective therapy, especially for patients with mutated IgHV disease, but I think we have better tolerated therapies now that are equally, if not more effective.
When you see second opinions in people who've gotten BR, is it usually an economic issue or lack of knowledge in the doc, or what's going on?
I think a lot of it has been practice patterns. I mean, if you've had good success with BR in the past, you might continue to do that, but I think it is really important to reconsider that given the great data we have for targeted therapies.
All right, Jennifer, let's talk a little bit about relapse refractory CLL.
Great. So I'm very excited to talk a little bit about selection and sequencing of therapy for relapse refractory disease. So to start, I just want to make sure we think about how we're approaching relapse CLL and remembering that especially for people who are experiencing their first relapse, our indications for therapy are actually the same as when we start our initial treatment. So there's not a need to treat asymptomatic early progression in somebody with relapsed CLL. You might consider it in somebody in their third or fourth or fifth relapse, but especially in the second line treatment. So relapse can take different forms. So in somebody who has had a time-limited therapy, has increase in white count, of course, this is not somebody you would treat right away. If you happen to get a CAT scan for some reason and you see new lymph nodes appear, but the person is completely asymptomatic, that is not an indication for therapy. A couple of scenarios where you might not treat immediately, but you know that treatment is coming is if you start to detect lymph nodes on exam, or in somebody who's receiving a continuous BTK inhibitor or a continuous treatment of any sort, who's having an increase in their white blood cell count. These are usually progressions that start slow and then become rapid, so require close monitoring, but not necessarily treatment at that time. And then, of course, somebody with relapsed CLL who has a return of autoimmune conditions that tend to be related to their CLL, symptomatic increase of lymph nodes and spleen, or return of fatigue or other constitutional symptoms, those are people who you're going to start on their therapy for relapse disease. So Matt went over very nicely the current frontline treatment regimens, but just remember we have continuous treatment with BTK inhibitors by themselves or acalabrutinib with obinutuzumab, and then of course our fixed duration regimens with either venetoclax with either obinutuzumab or BTK inhibitors, or in some cases all three. So how does initial treatment impact subsequent choices? And I think one of the things that I hope that you take away from this is that subsequent therapy is really highly dependent on what you choose for frontline treatment. So we really have to be thinking about sequencing as something that is important in the frontline setting as well. So what do we do if our initial treatment was a fixed duration therapy, whether it was chemotherapy, hopefully in the past, or more recently venetoclax with obinutuzumab or a BTK inhibitor, and then how is that different from a patient who has been treated in the frontline setting with a BTK inhibitor given continuously? So let's start by thinking about what to do if the initial treatment was fixed duration. So most of our studies that have established the standard of care for relapsed refractory CLL are in a chemotherapy-treated patient, or chemotherapy-treated patient. So when we think about what to do after chemoimmunotherapy, you can look to basically any data set that we have. Matt showed you some of these data already, but we know that the BTK inhibitors, ibrutinib, acalabrutinib, and zanubrutinib all can produce extended progression-free survival after chemoimmunotherapy. So here we have the ELEVATE-RR study in high-risk patients, acalabrutinib versus ibrutinib, showing the acalabrutinib to be non-inferior, and then subsequently the ASCEND study. And in this trial, which was not selected for high-risk patients, at 42 months, 62% of patients remain in remission. Then on the ALPINE study, again with zanubrutinib versus ibrutinib, at that same about 3 years or so, more than half, so almost 2/3 of patients treated with zanubrutinib remained free of progression. We also have seen data with venetoclax, primarily with rituximab, although based on the CLL13 study with ven-rituximab and ven-obinutuzumab, we often are incorporating obinutuzumab into relapsed therapy. But the data really exists primarily with venetoclax plus rituximab based on this Murano study here, where venetoclax plus rituximab given for 2 years after initial therapy has a median progression-free survival of about 54 months. On the right here, you can see the impact of minimal residual disease on the progression-free survival. So those people who at the end of therapy were MRD undetectable had significantly longer remissions than those people who had, of course, like gross disease or just MRD positive disease. Kind of getting back to what Con had mentioned before, this didn't change how you would treat these patients, but can be very reassuring for somebody at the end of therapy if you know that they do not have any residual disease in their blood. So then what if the initial therapy was venetoclax plus obinutuzumab? And I think primarily we can use the same strategy we would use for somebody who had previously been treated with chemoimmunotherapy. So BTK inhibitors, of course, are an option, and really any of them, primarily the second generation inhibitors, but either acalabrutinib or zanubrutinib could be considered. You could also consider repeating your initial therapy depending on the remission duration. So let's think a little bit about the data behind that approach. So repeating venetoclax obinutuzumab, which is becoming increasingly of interest. So most of the data up until recently has been either anecdotal or retrospective. So with the Murano study, there has been some data with retreatment with venetoclax plus rituximab. I think there's more at this point, but when this was updated in 2022, at that point, 18 patients had received subsequent venetoclax post-relapse. So remember, these are not people who got venetoclax in the frontline setting. These are people who had a number of prior therapies, usually chemotherapy, and then venetoclax rituximab, and then again venetoclax-based therapy. And here the overall response rate was 72%, and a very small number of patients achieved a second complete remission. There was also a multi-center retrospective study which looked at 46 patients. Again, primarily they had received venetoclax initially as a relapsed refractory therapy and then went on to receive venetoclax again. Here the overall response rate was almost 80%. Median progression-free survival was 25 months. So this is suggesting, at least in this situation, that because these people probably got another 2 years of venetoclax, that you're going to see remissions for about the same amount of time as you give the venetoclax, again, if you're doing it in relapsed CLL. So Matt presented earlier this year some initial data from a study called REVENGE, which is looking at retreatment with venetoclax plus obinutuzumab. So here, 25 patients had been treated at this point who had gotten to the end of treatment. All patients responded, primarily partial responses, but some complete responses as well. And many of the patients did have undetectable MRD at the end of this treatment. So I think this is going to be really important as we see more and more patients being treated on this trial to see how effective venetoclax obinutuzumab is when given as the second therapy rather than as kind of the third, fourth, or fifth therapy. And I think also remembering that, as in the case of everything else in cancer, if you give the same treatment again, you're likely to see a little bit of diminishing returns in terms of the response duration. So I think response duration in this setting is going to be really key. So what if the prior treatment was venetoclax with a BTK inhibitor? So there is no prospective data yet for this scenario. However, every study, to my knowledge, of a BTK inhibitor with venetoclax, with or without obinutuzumab, has looked at least in some fashion at people who progressed and whether they acquired mutations in BTK, PLC gamma 2, or BCL2 that would make retreatment with that agent not appropriate. And so far, the data is pretty universal that people do not acquire resistance mutations after these fixed duration regimens. And again, more and more data is being collected, and there will be additional data coming out in the next few years looking at actual retreatment approaches here to see whether the mutational data matches what we'll see clinically. And then what about if the prior treatment was a covalent BTK inhibitor? And as Matt showed before, this is how most patients are being treated at this point. So if the first treatment is a covalent BTK inhibitor and the BTK inhibitor is actually discontinued for toxicity, these are settings where I think it is helpful to check for mutations in BTK or PLC gamma 2. Whether they exist or not, treatment with an alternative covalent BTK inhibitor is going to be effective at least for some period of time. And there's a lot of data now that you can switch among the BTK inhibitors if somebody experiences a toxicity with one, they're not all that likely to experience the same toxicity with an alternate covalent BTK inhibitor. We know, though, that for people who relapse while taking a covalent BTK inhibitor, all of the covalent BTK inhibitors have the same drug binding site and all have the same predominant mechanism of resistance, which is acquisition of a mutation in that drug binding site. And when that happens, the covalent inhibitors bind non-covalently, if they bind at all, and the binding kinetics and the short half-life of all these agents make them a lot less effective. However, importantly, all of the mutations that have been observed in BTK while people are treated with BTK inhibitors, they actually don't affect how dependent the CLL is on the B-cell receptor pathway, suggesting that continuing to target that pathway and with alternative means remains a very good strategy. And then in addition to that C41 mutation, we've seen in a few different studies at this point that the second generation BTK inhibitors can also produce other mutations. They tend to have less PLC gamma 2 mutations, it seems, but we do see a few more of those. L528W, the kinase impaired mutation with zanubrutinib, and gatekeeper mutations like T474I with acalabrutinib. And really the mechanism for why this happens is not entirely clear. So what do we do in these patients? We've known for a long time now that venetoclax is effective in the post-BTK inhibitor setting. So this is a setting where we actually do have some prospective data, although at the time this study was performed, venetoclax was given as a single agent and given continuously, so quite a bit different than how we're giving it now. So this was patients who had previously been treated with either ibrutinib or idelalisib, and then gone on to venetoclax at the time of relapse. Also important to remember, these were very highly refractory patients, so many had had 4 or 5 prior lines of therapy. But in the setting with continuous venetoclax given by itself, the median progression-free survival was almost 25 months after patients had received ibrutinib, suggesting that in the setting where we're using BTK inhibitors now, primarily frontline or second-line setting, and with the addition of an anti-CD20 antibody, we're probably going to be getting better results at this point. So, of course, non-covalent BTK inhibition has been a very exciting strategy as well for people who progress after a covalent BTK inhibitor. So this is just a little schematic of how these types of drugs bind. So, as mentioned, covalent BTK inhibitors, of course, bind covalently to the C41 site. The non-covalent BTK inhibitors just kind of sit in the binding pocket a little bit different. So they will have a number of points of contact with BTK that all have reversible interactions, and they all sit and bind distinct from that C41 site. Matt showed some of these data already, but this was the phase 1/2 study of pirtobrutinib for previously treated CLL or SLL called the Bruin study. And in this case, again, relatively highly pretreated group of patients, the waterfall plot looking very promising for lymph node shrinkage in almost all patients. We do see, as is the case with other BTK inhibitors, that most of the responses are partial responses. When looking at progression-free survival on this trial, the median PFS was 19.6 months. And over on the right, you can see this broken down by people who had previously received a BCL2 inhibitor, again, primarily venetoclax, versus people who had never had a BCL2 inhibitor. And you can see that the median PFS for those patients who were BCL2 inhibitor naive was much longer at 22 months compared to 16.8 months for those people who had previously received a BCL2 inhibitor. I don't think it's clear whether this has anything to do with venetoclax or with BCL2 inhibition, but this group of patients had one less prior line of therapy on average, so it may just be that more lines of therapy leads to shorter PFS with pirtobrutinib. So that was the phase 1 data, and we've now seen data from the phase 3 Bruin 321 study, which was pirtobrutinib versus dealer's choice of idelalisib rituximab or bendamustine rituximab. And here we see here clearly pirtobrutinib is better than those alternative therapies. And average remission duration, or median PFS, is pretty similar to what we saw in the frontline setting. So we're still seeing about 1.5 years or so of PFS following pirtobrutinib. Importantly, though, with pirtobrutinib, we see a little bit of a discrepancy between progression-free survival and time to next treatment. So even though we're seeing that the PFS is only a little bit more than 1 year, the time to next treatment with pirtobrutinib is actually approaching 2 years. And this is probably because in this clinical trial, you're doing serial CT scans where you might pick up otherwise asymptomatic progressions, but also emphasizes that with BTK inhibitors in general, and I think especially pirtobrutinib, you do tend to see very slow disease progression, at least initially. So just seeing disease progression on pirtobrutinib does not mean you need to switch therapy right away. And so again, in Bruin 321, we see this difference between patients who had previously been treated with venetoclax versus those who had not been previously treated with venetoclax. Again, whether it's venetoclax per se or whether it's just an additional line of therapy is not entirely clear. But here, the median time to next treatment for those people who had not received venetoclax was almost 30 months compared to 20 months for those people who had previously received venetoclax. And based upon the Bruin 321 study, the FDA just 2 days ago actually granted full approval to pirtobrutinib for CLL and SLL. And this is for people who had been treated with at least a covalent BTK inhibitor before. So the initial accelerated approval said that they had to have had 2 prior therapies, including BTK and BCL2 inhibitor. And this has made this quite a bit more liberal in terms of removing that requirement for a BCL2 inhibitor. So then again, we do have a couple of pirtobrutinib abstracts that are going to be presented during this meeting that are really, I think, very exciting. So this is the Bruin CLL 314 study. And as mentioned before, this was previously treated or untreated CLL. The patients were stratified by 17p deletion and number of prior lines of therapy, and then randomized 1-to-1 to receive pirtobrutinib or ibrutinib. The primary objective of this study was to look at overall response rate, and specifically whether pirtobrutinib's overall response rate was non-inferior to ibrutinib. And you can see here with this star that in the entire patient population, the overall response rate of pirtobrutinib was not only non-inferior, but actually superior to ibrutinib. Importantly, and I think really interestingly with this study, we're seeing that the overall response rate in the treatment-naive patients is pretty compelling as well in favor of pirtobrutinib. So 92.9% response rate for treatment-naive patients treated with pirtobrutinib compared with 85.8% for patients treated with ibrutinib. And then PFS is actually descriptive at this time. The formal PFS analysis will be later, but also trends towards favoring pirtobrutinib in all of the patient subgroups. And then, of course, as we've seen before with pirtobrutinib, the rate of atrial fibrillation is a lot less with pirtobrutinib compared to ibrutinib, and dose reductions due to toxicity were also quite a bit less. One thing I think is really interesting and actually quite important with this study, too, is that discontinuations for toxicity were actually the same on both arms. So suggesting that you're not seeing that pirtobrutinib is potentially working better just because patients on ibrutinib were stopping treatment. And then, of course, we also have the 313 study, previously untreated CLL. In this case, they could not have 17p deletion, and then randomized to pirtobrutinib or bendamustine rituximab. And this study did include a crossover that was optional at progressive disease. Here, the primary endpoint is progression-free survival, and as you can see, very highly favors pirtobrutinib compared to bendamustine rituximab. So 24-month PFS with pirtobrutinib, a little over 93% compared to 70.7% for people treated with BR. Here as well, the discontinuations for toxicity very much lower for pirtobrutinib compared to bendamustine rituximab. And then again, reassuringly, the AFib rate is pretty low with pirtobrutinib. And one thing from the abstract too is the overall survival actually was significantly improved for pirtobrutinib compared to BR. And this is despite that crossover that's built in and a 52.9% effective crossover rate. So over half of the people who were eligible for crossover did actually cross over, and you still see an overall survival advantage, which is pretty impressive. And then to end, I'll just show you one slide with nemtabrutinib. So nemtabrutinib is another non-covalent BTK inhibitor. The difference between this and pirtobrutinib is while pirtobrutinib is very highly selective for BTK, nemtabrutinib is very non-selective for BTK. It actually inhibits the whole TEC family of kinases and the whole SRC family of kinases. The phase 1 experience was very positive with nemtabrutinib as well. Overall response rate in patients treated at the 65 milligram daily dose was 57.9%, primarily partial responses as you would expect. And then on the right is the duration of remission, which looks very good for those patients who did achieve a response with nemtabrutinib. The nemtabrutinib is currently in phase 3 studies that are ongoing. So to conclude, a few take-home points. As mentioned, sequencing of therapy really begins in the frontline setting. So as you're choosing your frontline therapy, it's important to think about what you're going to do as your next treatment. The fixed duration regimens do offer the potential for retreatment, and I think we'll get accumulating data for how successful that approach is going to be. Non-covalent BTK inhibitors are very effective after the use of covalent BTK inhibitors, and these two studies that will be presented at ASH this year demonstrate the potential for pirtobrutinib prior to the covalent BTK inhibitors and even in the frontline setting. And as Matt mentioned before, I think this is a really exciting year for CLL at ASH. So thank you very much.
A lot of stuff there. That survival benefit hazard rate was pretty low too. Is that seen with the other covalent BTK versus BR?
No, I don't actually think that magnitude of survival benefit has been demonstrated with the covalent BTK inhibitors, and actually most of them you don't necessarily even see a survival advantage. They did with FCR versus ibrutinib or rituximab, and I think have with zanubrutinib as well. But I think that's actually really impressive.
And again, any data on covalent after pirtobrutinib, even anecdotal?
I don't think there's any data.
Any experience? Interesting. So, Bita, curious about your approach to retreatment with patients who've got time-limited therapy, either obin-ven or now BTK-ven. How are you thinking that through, and what specific numbers are you looking for in terms of time to relapse?
Yeah, that's a great question. So normally, it's really rare for someone to progress on venetoclax, but I look at the PFS one of about 2 years. So if someone has had a good 2 years from their first exposure, it does make sense to re-challenge them with basically venetoclax, obinutuzumab, or BTK inhibitor, the combined BTK inhibitor and BCL2 inhibitor.
All right, let's get into some cases here. Again, we have Dr. Battinger with a 77-year-old man who's got a patient with a high-risk del-17p disease and has progressed now first on ibrutinib and now on ven-obin.
I have a 77-year-old patient who has relapsed CLL with high-risk features, specifically a TP53 deletion. He's been through several lines of therapy, including ibrutinib, 420 milligrams daily for 18 months. He had disease progression after that. He then went on to receive obinutuzumab and venetoclax, which he tolerated very well, and went into an MRD negative remission following treatment. But he relapsed very recently, earlier this year, after he presented with pancytopenia. We did a bone marrow examination on him and it showed relapsed CLL, SLL. He was then recommended to start pirtobrutinib 200 milligrams daily, which is what he's currently on, and his blood counts look much better. So my questions are, what is the role of pirtobrutinib in relapsed refractory CLL, and what data support its use specifically in TP53 deleted patients or any other particular patient subset? Where are you placing pirtobrutinib in CLL therapy sequencing?
So, Matt, can you talk a little bit about your experience with, quote, double refractory patients? What's the typical scenario? How you think through therapy, and when do you start thinking about CAR T?
Yeah, so I mean, this is a patient where I'd want to know what was the duration of response to that Ven-Oben. If it was long, like 2 years or more, I'd probably want to try Ven-Oben again before going to Pirto, but it sounds like it was probably short. So this is a typical patient where we'd be using Pirto, and I would say in my practice, my experience has been pretty similar to what we've seen in the trials, where most patients will respond well initially, 80+%, but the duration of that response is not so long. 14 to 16 months is kind of what I'm seeing as well. So this is a patient, especially at 77, where they might only have a shot at CAR T once, and that might be pretty soon as they get older. So this is a patient where I might start Pirto, but already be kind of thinking about CAR T as a next step, maybe as using Pirto as a bridge.
So here's another case. This is an 82-year-old man, IGVH unmutated disease, previously got FCR and actually was observed for a number of years after that, then got a CALA and actually for 5 years and then had progression. But when progression had a BTK C481S resistance mutation. Here's Dr. Rudolph.
I specifically queried him for a mutation on acalabrutinib for the C481S resistance mutation, and sure enough, he does have the mutation. Pirtobrutinib has been approved in this space, so I switched him to treatment with pirtobrutinib. He is tolerating the medication well. I could have switched him to venetoclax as well as an option. Fortunately, his insurance did approve pirtobrutinib without any questions, even though on label you have to fail a BCL2 inhibitor before giving pirtobrutinib. However, I chose pirtobrutinib because of the specific C481S mutation, and I would love to know the expert's opinion as far as choosing one over the other and how that might play into the future treatment choices for this patient. And I'm happy to switch him over to venetoclax if that might be better for him, and save pirtobrutinib for later, but I would love to know why. Also, at what point should I refer him for consideration of CAR T therapy? He is 82. He does have history of coronary artery disease. However, he is at this point in pretty good clinical condition. I don't know that there would be any reason to preclude him from CAR T therapy. I would also like to know where the data is, or if there's any data with regards to bispecific antibodies in management of relapsed CLL.
So, Con, interesting question. I didn't actually pick it up when I saw the recent approval that it when I spoke with Dr. Rudolph, that was the indication, but now it's kind of moved up. You can give it second line, right? You don't need prior venetoclax. So, in what situations would you give pirtobrutinib second line? Would you take into consideration a BTK resistance mutation?
Yeah, so this is one where I think Jennifer has touched on very briefly, but we need to know what other mutation this patient carries. So we need to understand what your lab reports. So all the labs report a 481 mutation, but there's a really good chance your lab doesn't actually look for other mutations. If you don't look, you won't find. And this patient had been on acalabrutinib, so there's about 1 in 3 chance they'll actually carry a T474 mutation, which is a cross-resistant mutation to pirtobrutinib. Now, what happens if you go into pirtobrutinib with a pre-existing resistant mutation? The data is pretty limited. From Bruin, it suggests that we do know that when the patients relapse from pirtobrutinib, that the outgrowth will be the resistant mutation. But patients often do have a duration of benefit despite having the mutation on board. So I don't think choosing pirtobrutinib is the wrong answer, but if this patient had a T474, I would be thinking that they will be probably not having a very good response, and I'll be lining up the next therapy pretty soon. And had I known the information ahead of time, I would probably chosen a venetoclax-based regimen just because of the mutation finding.
So we're going to move on in a second and talk again about CAR T and other novel strategies, but just sort of get ahead of that a little bit, Matt. What do we know about bispecifics? The last question Dr. Rudolph brought up.
Yeah, so it's early days, but the data so far with epcoritamab look promising. I was actually very pleasantly surprised that in their small study of CLL patients who were generally very refractory post-covalent BTKI, post-BCL2 inhibitor, they saw close to a 40% CR rate with epcoritamab as a monotherapy. So I think the drug is clearly active in CLL. You can imagine if you move it into earlier lines, it might be even more effective. So I'm excited to see more data on it.
Talking a lot about bispecifics tonight when we talk about NHL, a huge issue there. But Bita, let's talk a little bit about CAR T and other novel strategies for CLL.
Okay, great. So this is going to be the outline of my talk. I'll start by talking about CAR T therapy, particularly lysocaptogen mareleucel, or Lysocell, which was approved for double refractory patients with CLL in March of 2024 in America. And then we'll talk about CAR T plus ibrutinib cohort and how adding a covalent BTK inhibitor potentially improved the outcomes. I'll switch gears and talk about bispecific T-cell engagers. There is data for epcoritamab and glofitamab. I will focus on the epcoritamab data, the EPCOR CLL trial. And then I will talk about Richter's syndrome, which is an orphan disease. These patients historically have been excluded from CLL trials and also DLBCL trials. But fortunately, epcoritamab, the results in Richter's transformation was presented at the IWCLL meeting, which I'm going to talk about. And then the real-world data of Lysocell in Richter transformation based on the CI-BMTR data. And eventually, we'll talk about BTK degraders, which you'll hear a lot about at this ASH. So focusing on CAR T therapy, before going into details, I really want to make sure that we all understand the concept of double-exposed and double-refractory patients. So double-exposed patients, you heard a lot throughout the conversation today. Those are patients that have been exposed to both a covalent BTK inhibitor and also a BCL2 inhibitor. And, they're going to be the focus of the research in the next few years because they've exhausted the most basically effective treatment options that they've had. But it's also important to make sure that we're getting all the mileage that we can and not prematurely label patients as double-exposed, double-refractory patients, as you just heard the incredible data about rechallenging, the potential for rechallenging these patients. So the Transcend CLL 004 trial was a phase 1/2 open-label multi-center study, including adult patients with relapsed refractory CLL. And then patients had to have seen at least 2 prior lines of therapy if they were high risk, defined as unmutated IGHV, TP53 aberrant disease, or complex karyotype with 3 or more chromosome abnormalities, or at least 3 prior lines of therapy if they did not have any of those specific features. Good performance status and also adequate organ function. Patients were leukapheresed with a median time to CAR T manufacturing of about 4 weeks, and bridging therapy was allowed. And then once the eligibility was confirmed, patients received lymphodepleting chemotherapy with fludarabine, cyclophosphamide. 2 to 7 days following completion of therapy, they received their Lysocell, and then they were assessed. There were 2 dose levels, 50 and 100 million cells, and then the dose level 2 became the recommended phase 2 dose. So in the Lancet, publication, there is longer-term follow-up, but the CR with incomplete count recovery was 18%, overall response rate of 47%, median progression-free survival of 1.5 years, and median duration of response of about 3 years. This was a heavily pretreated patient population, as you can imagine, with a median age of 65. The middle column is particularly focused on the so-called double-exposed patient population. Patients had median 5 prior lines of therapy ranging from 2 to 14. And in terms of high-risk features, you see that about 45% of patients have deletion 17p, with half of those patients having TP53 mutation. Almost all patients had to have prior exposure to a BTK inhibitor, and 71 patients were exposed to both a BTK inhibitor and a BCL2 inhibitor. And about 80% of patients received bridging therapy before receiving their CAR T therapy. In the longer-term follow-up, at a median follow-up of 31 months, the CR was 20%, and the overall response rate was 48%. The UMRD4 rate in blood was about 60%, and it was basically the same in patients with double-exposed, double-refractory patient population. And here you see on the left, the median progression-free survival was 18 months in blue for all comers. And if you look at the right, particularly for patients with double-exposed disease, that median progression-free survival was slightly shorter than a year at 11.9 months. And I do acknowledge that cross-trial comparison is fraught with bias, but you just heard from Jennifer that the median progression-free survival for the very population of double-exposed, double-refractory patients with pirtobrutinib was 16.8 months. So in terms of toxicities associated with CAR T, we do worry about CRS and neurotoxicity. So you see about 85% of patients developed any grade CRS. And if you look at basically high-grade CRS, 8% of patients developed grade 3 CRS with no grade 4 or 5. In terms of ICANS or neurotoxicity, about 19% of patients developed grade 3 and 4 neurotoxicity with no grade 5 events. I never advertise CAR T as one and done. There are long-term toxicities, particularly prolonged cytopenias reported in north of 50% of patients, grade 3 or higher infections in 1 out of 5 patients, and second primary malignancies in about 10% of patients. So just remembering the CR of 20%, overall response rate of 47%, and a median progression-free survival of 18 months, now we are moving to the cohort that combined liso-cel with ibrutinib, and the rationale is ibrutinib in particular, but BTK inhibitors in general, ibrutinib has that ITK inhibition, which will result in T helper 1 enhanced immunity, increases CD4, CD8 cells, it improves immune synapses, and it also reduces the T cell exhaustion and pseudo-exhaustion. So the rationale behind this cohort is let's improve the T cell function in a disease where patients have inherently dysfunctional T cells, so no matter how manipulated, at the end of the day, the results are not going to be as impressive as what we see with our lymphoma patients. So about 65 patients were originally included in this cohort with 51 efficacy evaluable patients, and you see the CR with incomplete count recovery improved from 20% to 45%. The overall response rate improved from 48% to 86%. And the median progression-free survival for all comers improved for 18 months to close to 2.5 years, corroborating the theoretical rationale behind combining liso-cel with a BTK inhibitor. All BTK inhibitors basically improve the T cell function, but ibrutinib particularly because of the ITK inhibition. So moving from CAR T to CD3, CD20 bispecific T cell engagers, the EPCORE CLL presented the expansion and optimization cohorts. So basically the major difference in the expansion cohort, the step-up dosing happened within 2 weeks, cycle 1, day 1, 0.16 milligrams, then cycle 1, day 8, 0.8, and eventually patients getting the full dose of 48 milligrams, whereas in cycle 1 optimization, which was in order to reduce the rates of CRS and ICANS, there was a cycle 1, day 15, 3 milligrams before getting to the full dose. So the primary endpoint for the expansion cohort was overall response rate, and for the optimization cohort was rates of CRS and neurotoxicity. Here you see in a heavily pretreated patient population, 70% of patients having unmutated IGHV, 60 to 65% of patients having TP53 aberrant disease, and median 4 prior lines of therapy, and exposed to all kinds of treatments for CLL. As you just heard from Matt, the overall response rate was 61% with complete response rate of 40%. And the response was seen in patients with TP53 aberrant disease with an overall response rate of 67%, unmutated IGHV overall response rate of 63%, and double-exposed patients with an overall response rate of 53%. And if you look at the UMRD4 and UMRD6 data, about basically 75 and 67% of patients achieved MRD negativity in blood. And if you look at the CRS and ICANS, particularly focusing on the dose, on the optimization basically cohort, you see that by doing step-up dosing throughout the first cycle, the rates of CRS and the rates of neurotoxicity particularly significantly reduced. And as expected, the majority of cytokine release syndromes happened after the introduction of the first full dose at 48 milligrams. So moving to Richter syndrome with the focus on epcoritamab, which we just talked about. So the efficacy data at IWCLL was presented for patients who received epcoritamab as their very first Richter-directed treatment, but the safety included all Richter's patients who received basically epcoritamab at any line of therapy. And here you see that epcoritamab was given weekly for the first 3 cycles, and then every other week between cycles 4 to 9, and eventually moving to once every month, with cycle 10 moving forward until disease progression or intolerance. Otherwise, very much similar to what we already talked about, looking at patients with first-line Richter treatment being epcoritamab. You see that 95% of those patients had prior CLL-directed therapy with prior median 2.5 lines of therapy for their CLL, ranging from 1 to 7. As mentioned, they were treatment naive for their Richters, median age 67, most of them high-stage lymphoma disease, and more than half of those patients had TP53 aberrant disease, and median time from diagnosis of CLL to Richter's transformation was about 12 years. And in this basically population, you see that the overall response rate was 57% with a complete response rate of 52%. And if you look at the basically Kaplan-Meier curves, the median progression-free survival was almost 9 months, and the median overall survival was slightly over 2 years. So what about CAR-T? We did discuss that patients with DLBCL were excluded from the Transcend CLL 004 trial, but also Transcend 001, which was liso-cel for diffuse large B-cell lymphoma. This is an effort by CIBMTR, which included Richter's patients. And in 30 patients with Richter's basically syndrome, the median follow-up, at a median follow-up of slightly over 1 year, the overall response rate was 76%. Median PFS was not reached, and the median overall survival was also not reached. Moving to BTK degraders. So BTK degraders basically hijack the cell's inherent protein disposal machine. So here you see in the dark blue molecule, they have 3 components. One, in the BTK degrader situation, attaches the BTK target. Then the other basically component attaches E3 ubiquitin ligase, and there is a connecting part. And through E3 ubiquitin ligase, they tag BTK through polyubiquitination. They add ubiquitin molecules so that this tagged molecule can then be degraded by proteasome. And the Cadence trial, this is all from the abstract that is going to be presented, is an ongoing phase 1/2 evaluating the B1 BTK degrader in patients with B-cell malignancies. Particularly, I'm focusing on CLL. Patients had to have at least 2 prior lines of therapy, and in the US, EU, and Australia, everyone had to have prior exposure to a covalent BTK inhibitor. And the primary endpoint was safety and efficacy in 67 patients. As of May of 2025, patients were treated between the doses of 50 to 500 milligrams, with 200 milligram being recommended as the phase 2, and is currently in trials for phase 2 and phase 3 with this BTK degrader. Median age 70, median prior lines of therapy 4, and you see that patients had exposure to covalent BTK inhibitor, 20% non-covalent BTK inhibitor, and also 82% BCL2 inhibitors, 65% had TP53 aberrant disease, and 80% unmutated IGHV. So a truly hyper-refractory patient population with a lot of basically bad features. In terms of safety profile, the most common side effects: fatigue, confusion, diarrhea, and neutropenia. And treatment-related adverse events resulted in the discontinuation in 12 patients. So in 66 basically efficacy evaluable patients, the overall response rate was 86%, particularly for the 200 milligram cohort. The overall response rate was 94%. The responses did deepen with time, and the 12-month progression-free survival was 80%. So talking about basically BTK degraders, I encourage everyone to also attend other BTK degraders that are being presented. Bexobrutideg, the Nurix BTK degrader, is going to be presented tomorrow. Jennifer will be presenting a very interesting molecule, basically having both covalent and non-covalent BTK inhibitor characteristics in one molecule, which is going to be presented tomorrow. And again, talking about novel therapy options, you did hear about sonrotoclax being a new oral BTK BCL2 inhibitor being investigated, and the results of lisaftoclax is also going to be presented tomorrow. So I also want to mention it is going to be an exciting year at ASH for CLL.
So before we get to the last case, Jennifer, curious about your thoughts about BTK degraders, the last thing that Bita just talked about. Should also mention that in the syllabus we have there a name for BGB 16673 that we had heard about, catadegrutamib, but apparently that is not the official name, so we'll wait and see what it actually ends up getting called. But Jennifer, kind of curious where you see these things heading. There's an estrogen receptor degrader that's been studied in breast cancer, but they already have selective estrogen receptor downregulators, so they may not proceed. Do you see BTK degraders coming into practice at any given point, and at what point?
I absolutely do. I think the data is really exciting in terms of the progression-free survival, the response rate, and in this patient population where we really don't have any other great therapeutic options. I do see the degraders being preferentially used after the kinase inhibitors. You know, we've seen that you can now sequence multiple kinase inhibitors in a row. And resistance mechanisms might allow another kinase inhibitor to work in that setting. With the degraders, they will work in the setting of almost all resistance mutations that have been identified. But the problem, I think, is going to come when people become resistant to the degraders. The mutations that have been seen at this point change the way that the binding pocket is, such that you really are not likely to be able to target BTK after. So I don't see it being a really great frontline strategy.
So one more case from Dr. Mulhern, a 72-year-old man who has received multiple therapies for CLL, now with an 18-month response to pirtobrutinib.
He's 72, but he actually has a great performance status. He began venetoclax, rituximab, and steroids, and although the autoimmune hemolytic anemia did resolve, the lymphocytosis did not improve and actually worsened, and the lymphadenopathy continued to worsen. And within a few months, we kind of declared that to be a failure, and he began pirtobrutinib. The warm autoimmune hemolytic anemia took a little bit, but within 2 months, he was no longer hemolyzing, and lymph nodes have slowly decreased in size, but they're still there. So we have actually talked to him. I think we have bought you time, but this is not going to work forever, and that we should refer you to an academic center to discuss the role of CAR-T.
How did he do on the pirtobrutinib? Any tolerability issues?
No, we tend to see less fatigue, less arthralgias, obviously less arrhythmias and bleeding and those kinds of things. But I think it's the best tolerated out of the group.
So, Matt, can you comment a little bit about this case and whether you'd be thinking about CAR-T therapy, and also the issue of bridging therapy with CAR-T?
It wasn't clear to me from this case whether this patient also had a covalent.
Yeah, he did.
They did. Okay, yeah. So then I would be thinking about CAR-T for this patient, sort of slow progression on pirtobrutinib. There's actually going to be some data at this ASH meeting of combination of pirtobrutinib with lysocell. It's retrospective data, but looks kind of similar to that ibrutinib plus lysocell with higher response rate, higher CR rate. So yes, youngish for CLL, 72, and pretty fit. This is a patient where I'd probably take them to lysocell, but also continue the pirtobrutinib.
So yeah, the patient had gotten Cala previously. Jennifer, can you talk a little bit about how you think through eligibility for CAR-T? Obviously, this comes up in a lot of different cancers in terms of age, comorbidities, particular issues that come up with CLL?
Yeah, so, as Bita mentioned, when given by itself, the complete response rate is pretty low. And we know that unlike some of our other treatments where MRD is what matters, with CAR T, patients who get a complete remission are the ones that have those very long durations. At this point, the things that might make it more likely to get a complete remission, as mentioned, treatment with a BTK inhibitor as well, and then people who've had less lines of therapy, and those that have less bulky disease going into CAR T. So I always try to get people into as good of a remission as we can. And if you're thinking about CAR T for an individual patient, I try to sequence it as early as possible rather than exhausting all other options before getting there.
So a couple final questions that came along from the audience. Coming back to you, Con. I was actually thinking about this when you were talking about skin cancers. Any issues with using IOs, like cemiplimab, but it's often used with advanced stage skin cancers and CLL?
Sorry, this is a PD-1 inhibitor?
Yeah.
Yep. No, there's no issues. In fact, there was a brief moment when we thought PD-1s may be good for CLL and Richter's. So from my point of view, we have a lot of patients who take CLL who end up on PD-1 inhibitors for their melanomas. They seem to work well.
And Matt, another question from the audience. You have a patient with high tumor burden CLL who's going to get venetoclax obinutuzumab. Would you consider admitting the patient to the hospital for the initial dose of obinutuzumab for TLS and infusion reaction maintenance?
Generally, no. We actually have started doing steroid pretreatment for those patients, actually for a few days, like 3 or 4 days of dexamethasone 20 milligrams, so pretty high dose. And then we were able to give the obinutuzumab safely in the outpatient setting. It does seem to help mitigate the infusion-related reactions. And if we do check labs for TLS with obinutuzumab, but it tends to be a more mild TLS that can be managed with fluids. It's not similar to the venetoclax where it was a very aggressive TLS.
What about hospitalization for typical indication in terms of high risk for TLS?
For venetoclax, yes. If there's a patient with greater than 10 centimeter lymph node bulk, particularly if they also have a high white blood cell count, and if they have sort of borderline renal function, we will occasionally still admit those patients, but most patients we can safely do it in the clinic.
A person in the audience want to know, do you see deaths with TLS?
Not since the very early days of venetoclax, fortunately. So with the currently approved ramp-up, it's very unlikely.
So I want to thank particularly the docs who presented cases today and also to the faculty. Thanks so much for coming here today.